Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Alan Feren, retired surgeon and patient advocate. Today's Kevin MD article is Fragmented Care Needs Clinical Direction, Not More Data. Alan, welcome back to the show.
Thanks, Kevin. Appreciate being asked to come back.
All right. So tell us what your latest article is about and why you decided to share it on Kevin MD.
I think the best way to present this is to give you a clinical vignette that's pretty common. Let's take a gentleman perhaps in his 60s, known pain in the hip, proven arthritic hip with bone on bone. He has comorbid conditions like prediabetes. He's managing his hypertension pretty well. He's got some early chronic kidney disease with elevated creatinine and BUN. He also has some residual chronic obstructive pulmonary disease, which is being managed by a pulmonologist. He's scheduled for surgery, and typically, as you know, Kevin, the primary care will be doing the history and physical examination. Mm-hmm. In this particular case, the pulmonologist and the nephrologist are not on the same EMR. The orthopedic surgeon assumes that the primary care will manage any conditions that arise. Primary care assumes that if there is a need for input from either the nephrologist or the pulmonologist, that they will be in touch. So the perioperative plan is in place. Patient undergoes the surgery. And here's the problem. No one is really directing the care. There's not a solid integration piece that's going on here, and the patient is left at the postoperative period to try to understand what he or she should be doing and what are the next steps and what is the treatment plan, what's the medication. So this is the situation where we have a place where the direction function has become somewhat diffuse. Mm-hmm. And the absence of direction can look like progress from the patient's perspective, but there's still confusion that's present. So the main question that I tried to address in this article is that a clinical encounter can be appropriate, but the overall course of care and understanding is perhaps not usable.
Now, as you know, this is a trend in medicine where everything is becoming more siloed and specialized. And especially if someone with multiple comorbid conditions, not only are they seeing the proceduralist, but they may have a cardiologist, they may have a nephrologist, they may have a pulmonologist, in addition to their primary care doctor. So there are 4 to 5 people on that team, and everyone has to be on the same page. Now, when you did procedures and you encountered patients like this, what was your experience in terms of who was the ultimate manager, the ultimate decision maker of the patient's treatment course?
Well, I think as I look back, because when I practiced, things were quite different than they are in today's medicine. My training was very steeped in the surgeon managing the care and making the decisions. So if I had a patient with a cardiac issue, I personally contacted the cardiologist to get cardiac clearance. If the patient had hypertension that was not being well managed, I asked for the primary care or the internist to assist in managing. Today, that's really not the case, as you've well pointed out. And what has, I think, made things even more complicated is hospitalists, mm-hmm. because there's sometimes not good transfer of information from the hospitalist to primary care, or for that matter, to whoever is specialty managing, since the patients are not really seen today by the primary care physicians.
Now, tell us some of the stories that you may have heard or the potential scenarios that can arise from patients slipping through the cracks and their clinical team assuming another physician is handling a medical issue. What are some of the dangers to the patient?
Well, the danger to the patient is that they don't have anything that's in terms of their treatment plan that's understandable and usable. They are then forced to make clinical decisions outside the clinical setting. I can tell you that I had a situation where I actually referred a patient of mine who was having a cardiac issue postoperatively to the incorrect cardiologist, and that this created quite an uproar for me, not so much for the patient because the patient ended up getting good care, but that was the last referral I ever got from that cardiologist. So you can run into that situation. But I think today the more common situation is uncoordinated care. And I want to make a statement about coordination of care or continuity of care. It's not the same as clinical direction. Someone still needs to synthesize the meaning. They need to put all the pieces together. And that's very difficult when you're forced to have high throughput and the EMR systems may not be communicating with one another. I currently have a primary care physician whose EMR is not the same as my specialty care physicians. And I am the person that has to integrate. Fortunately, I have the knowledge and expertise, but not everybody does. So it can become a problem. When I have labs done, I have to notify my primary care that I've had labs done by the nephrologist or my cardiologist. And patients should not be put into that situation. They don't have it's not really medical expertise, it's really a health literacy and asking them to make clinical decisions that they're really not able to do,
So
nor should they do.
So there's a little bit of a tension here, and you mentioned hospitalists, and one of the reasons why hospitals exist was because it was a little bit too onerous for primary care to round in the hospital in the morning and then see patients in the afternoon and get called by the hospital while they're seeing patients. But so from almost a lifestyle work-life balance, sometimes there is an impetus to become more siloed and segmented, but there's a tension versus, of course, fragmented care and miscommunication and continuity of care. So what's the answer here going forward? Given the trend and trajectory of our healthcare system and more doctors being more specialized, what do you see as the potential answer here?
Well, I think it drops down to self-advocacy
Hmm.
so that when patients are undergoing a procedure or have multiple comorbid conditions, they need to ask to try to identify who's directing their care. And so, some questions to ask: who's helping to put all these different opinions that I'm getting together? And what is my current working diagnosis? What is the concern that I should be most focused on and needs to be addressed first?
Hmm.
Tell me what remains unresolved, what would change my treatment plan depending upon the outcome of all these different things, and who's responsible for what, and what are the next steps, and what should we do to reassess when things are not improving. So this really puts the patient in a situation, unfortunately, where they have to define and identify who's directing their care. On the clinician side, I think there are a few things that they can do differently, and that is when you are taking care of a patient who has multiple comorbid conditions, which is clearly more common today than in the past, speak with them and say, yeah, here's what this is how I'm putting all these pieces together. And here's what I believe is most likely. Here's what I think is most uncertain. And here's what will change the treatment plan. And this is who you should see to follow up next. AI, I think, can be helpful. It can support direction, but it's not really a substitute.
It is a commentary on the healthcare system in that primary care physician should be the one that does everything that you said, but there's a primary care shortage. Not every patient has a primary care physician and are being managed by a cadre of specialists. So, like you said, the onus has to be on the patient to be more proactive in coordinating their own care. Now,
Absolutely.
you did mention AI. So you said that AI could be a tool to help. Give us an example of a scenario where a patient can use AI to help them?
Well, I think in examining your particular diagnosis, there's a lot of good information that's available. Of course, it's always important, and this would be the proviso that I would tell all patients, is to make sure that that you investigate the sources from AI. And you can go on typical sites such as Cleveland Clinic, Mayo Clinic, National Cancer Institute. Sites like that have a good series of questions that can be available to ask your clinician if you're undergoing a procedure or have a diagnosis that you're not sure how things work. I just recently had a call from a family member. I direct a lot of care for family and friends regarding a drug called Prolia, which is for people with osteoporosis. And it's a diabetic woman who has great concerns about taking this drug because it does have a lot of side effects, as we are aware. And it was a situation where I ended up going to AI, which is open evidence for us, and we're fortunate to have that, to review and ask the specific question. I am a diabetic patient. I am X years old. I've been recently diagnosed with osteoporosis, having been osteopenic prior to this diagnosis. And I have concerns about taking this drug and the possible complications. Are there contraindications for me based upon the literature? And you get a very good sense for what that is. Now, obviously, patients don't have access to open evidence, but there are other sites that are available through AI that can give them good direction. But again, it's important to thoroughly review what these sources are, because there's a lot of disinformation and misinformation and a lot of what's called AI slop on the net.
Sometimes when a patient has multiple clinicians caring for them, there's conflicting opinion. In the absence of a primary care physician or someone leading the proverbial ship, what's a patient to do when they have specialists' opinion that conflict with each other?
I think it's important for them to take the conflict, identify what that conflict is, and speak with one of the physicians whom they trust. Obviously, they must trust each of the physicians, but most patients will have a clinician that is their quote unquote favorite. And ask that question, just saying, well, Dr. So and so told me I should be doing this, but the other doctor told me that I should be doing that. What is your take on this?
We're on to Alan Feren, a retired surgeon and patient advocate. Today's Kevin MD article is Fragmented Care Needs Clinical Direction, Not More Data. Alan, as always, when will your take-home messages to the Kevin MD audience?
My take home message is that when direction is missing, patients are forced, in essence, to make clinical judgments that are outside their capability and outside the clinical setting. And even though it looks like there's progress that's occurring from the system's perspective, what patients end up with is confusion. So to obviate that confusion, ask the series of questions that I've identified as being important. Make sure that you understand who is directing your care, and that should be the main person who is going to be in charge of putting and integrating all the pieces together so that you have an understandable and usable treatment plan.
Alan, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thank you, Kevin.